I had the pleasure of meeting Dr. Mangin a few years ago, and she kindly came and presented at one of our conferences and spent some lovely time with her. She's a wonderful person to spend time with and very knowledgeable. And we were lucky to have her. Dr. Mangin's broad interests include rational prescribing with a focus on matching burden of care with capacity to benefit, innovative models of primary care service delivery, and the influence of science, policy, and commerce on the nature of care. She has wide clinical research experience in primary care, including observational and interventional quantitative research methods, and has led community randomized control trials of innovative models for care, deprescribing trials on the reduction of single medicines, and deprescribing on multiple medicines among older adults. I've learned a lot from her over the years, and really excited to learn more about her recent published experiment. And we're so happy to have you, Dee. And with that, I'll turn it over to you.
Thanks, Aaron, and hi everybody. Good afternoon. Well, it is afternoon for me, and it's really nice to see in the name so many friends on the call from BC and Alberta and Winnipeg. So it's really nice to be able to join you. And just probably the most important thing about my bio is that I'm a family physician in clinical practice, just like the majority of you on the call. And so that's really my perspective on this topic that I hope to share with you. So I'm just going to go through the mechanics of sharing my screen. So just bear with me for a couple of minutes. And if somebody could just let me know when you can see the full slide view, that's great.
Yeah, it's perfect.
Okay, so I'm going to share with you some of my perspective on stopping antidepressants. And you're probably on this call because you found, as the title says, that breaking up can be hard to do. And I'm going to give you some context in the first part of the presentation, which will hopefully give you the background to the second part. Can we get to the good part, which is the practical approaches of how and when to do this in primary care. So we want to start with a land acknowledgement. So I'd like to recognise and acknowledge the traditional, ancestral and unceded territory of the Anishinaabe and Haudenosaunee from which I'm working today. This land is within the lands that are protected by the Dish with One Spoon Wampum Agreement. And I recognise that my own relationship with the stewards of these lands is both part of the global colonisers of the lands and culture of Indigenous peoples, but that includes my own country of birth, New Zealand, and also my presence as an immigrant to this country. And I think this idea of stewardship and recognising that is also translatable to health. There are existing models among Indigenous peoples of Canada for stewardship of health, and a lot of strength within the First Nations conceptualisation of health, which is much more holistic than a biomedical approach and very pertinent to the area that we're talking about today. There's much we can learn from this and a sustainable understanding of an approach to health and healthcare, and if we listen and embody that in the broader health system. So a two-row wampum approach really means a true partnership, which can improve healthcare for all of us, as embodied by this wonderful piece of artwork here. So just the other housekeeping piece I have to do before the talk is that I need to declare my conflicts of interest. I have no commercial conflicts of interest, but you do need to know that I've had public research funding from these entities, and this funding has been for 5 of the studies mentioned in this talk. So the focus of what we're going to talk about today really is on this patient that is in my schedule for 10:15 this morning. So a 69-year-old woman who has come in just for a repeat prescription of her fluoxetine, which she's been taking for 5 years with really no issues. Now, you've already seen 3 patients and had a lab that you've got to act on, and you're already running 20 minutes behind. So how do you deal with this? I hope through this talk you'll be able to understand some of the issues around prescribing of antidepressants, and particularly long-term prescribing, examine some of the evidence for effectiveness in primary care patients, and then understand some practical approaches to shared decision-making and conversations with patients around discontinuations versus continuation of maintenance SSRIs, and to understand some practical approaches. So Houston, we have a problem. You can see here, and you're probably all very familiar with what's been going on, is that the rise in the prescription of new antidepressants has gone up and continues to go up. And this is it's a graph from New Zealand, but it's the same graph, same shape in the UK and Canada, in most developed countries in the world. And this prescription rate is driven, it's not that we're starting this volume of people on prescriptions, it's the fact that people who are starting on prescriptions are continuing on them, to the extent that in the UK, for example, 17% of the adult population, have received a prescription for an antidepressant in the last 2 years. And in most countries, including Canada, if you walk out in the street, the number of people around you who are currently taking an SSRI antidepressant will be in double digits. Now, that to me is a John McEnroe, you cannot be serious piece of data, because it's not really conceivable that more than 1/10 of us are so medically unwell at any one moment in time that we need to be taking an antidepressant. And this increase in long-term prescription is driven by a few things. It's driven by these kinds of recommendations that have been in guidelines for years now for maintenance treatment, and the kind of recommendations for who should have long-term treatment, you can see here, are really loose. And I would challenge any of you to not fit the criteria of the last couple of years for ongoing psychosocial stressors. So you can see here that this kind of thing is one of the things that's driven this real rise in long-term prescription. So the summary of the problem that we're facing, and that we'll talk about today, is that many guidelines do recommend maintenance treatment, but it's very unclear who will truly benefit from this. And there's little evidence, or has been little evidence, to support this, but this use beyond the acute episode is driving this widespread SSRI use. And there are increasing reports of adverse effects of long-term use. So just looking in a little bit more detail at some Canadian data. So this is a study that we did a few years ago now, using our local practice-based research network at McMaster. And what we did was we looked at legacy drugs. So legacy drugs are drugs that are appropriate at an initiation and when prescribed for an intermediate period. So they're prescribed for longer than, say, a course of antibiotics, but they weren't ever intended to be a life sentence. So they assume legacy status, if you like, when they're not appropriately discontinued after that intermediate prescription duration. So we looked at 3 kinds of legacy prescriptions: one for physical symptoms, PPIs, one for a risk factor, which is bisphosphonates, and one for psychological symptoms, which is antidepressants. And we just defined for the purposes of what we're talking about today that a legacy prescription was one that went on for 15 months or more. And this is what we found. So that if you're started on an SSRI antidepressant, the likelihood of you receiving a prescription that goes on for 15 months or more is 46%. Now that's way above the proportion, even in the most loose definition that comes under that recommendation for long-term maintenance use. And it wasn't just a little bit of slippage. You can see that the mean duration for that prescribing was approaching 5 years. And the other thing we found is that this is an amazing opportunity for us to really improve prescribing, because we found of those patients we looked at in that cohort that nearly 2/3 of them were still currently taking that legacy length prescription. So it's a great window of opportunity for us to really improve our practice and improve things for patients. The other interesting thing was that we found that SSRIs are involved in upstream and downstream prescribing cascades. So we found that it was very common, unlike the other drugs that we looked at, but to see co-prescription of SSRIs and PPIs compared to other combinations. So 1/3 of those who were prescribed an SSRI were also co-prescribed a PPI. So it may be that there's a hidden prescribing cascade with the GI symptoms that we know that some people who take SSRIs experience. I read once that there are more serotonin receptors in the gut than in the brain. There was also a recent study that I've referenced at the bottom there, that shows that a third of adults in the US are currently taking a drug that can cause depression. So that's that upstream prescribing cascade. So the take-home message number one is that we really need to pay attention and think about stopping as much as starting antidepressants. And we also need to remember both upstream and downstream that these medications can be part of a prescribing cascade. In that study that I was mentioning about the drugs that cause depression, it was found that the depression diagnosis prevalence, if the person was on greater than 3 of those medications, was 15% compared to 4.7% if they weren't, and nearly 10% of the US population were in that 3+ group. So it's drugs like H2 blockers, ACEs, some anxiolytics, ibuprofen, beta blockers. All of those medications can potentially affect mood. So what are the other barriers at system level that stop us from leaping into this void? And one of them is fear. And I think we have a natural fear, and patients do as well, of not wanting the depression to return. So on the one hand, there's a tension between not wanting to prescribe a medication that's not useful or is unnecessary, and we and patients would agree on that, but also neither is, the experience of depression is a horrible one, and neither want to that to return either. And so sometimes the easiest approach seems to be to address those fears, to think, well, let's not rock the boat. And there are two reasons really to think about a little gentle boat rocking. The first is, how much is this ongoing prescription really helping this person? And we know that that most of the effect that we do see with prescription of an antidepressant is placebo effect, and I know I can't tell the difference between whether the response has been a placebo response or not. And we also know that the primary function of antidepressants is to mitigate the symptoms of depression until the episode goes away. So there has been a disease myth that's linked to the serotonin hypothesis that was a commercial marketing myth, that somehow depression is linked to a lack of serotonin, and that SSRI somehow replace that. But really, most of the antidepressant medications that patients find helpful act to mitigate the symptoms until what naturally happens with an episode of depression. Even if you do nothing and take no medication, the episode's natural history is to remit. So thinking about duration is really important as well when you're thinking about considering the benefits. So I'm just going to touch on some other things that are important in thinking about the literature when thinking about the potential benefits for our primary care patients. So the first is our setting. Then there's the publication bias, trial quality, and multimorbidity. So these all affect our conversations with patients. So this is a really famous image now, and many of you may have seen it before, but this is a really lovely visual demonstration of publication bias with the SSRI antidepressants. So this was an example of all of the published studies that went into a Cochrane review and meta-analysis of antidepressants. And Eric Turner, who wrote this very famous paper, was also on an FDA review panel and was aware of all of the unpublished studies as well that had been submitted to FDA. And he analysed this and showed that you see a very different picture in terms of the efficacy when you remove that publication bias. And there's nothing special about antidepressants. We know that this bias exists for most classes of drug, and it kind of makes logical sense, really. If you're a pharmaceutical company, there's not an incentive to publish a negative trial. Looking specifically at the trials of antidepressants in our primary care setting. So this is what's called a funnel plot. And a funnel plot is a way of, when you're doing a meta-analysis, you assess all the studies to see whether you can see evidence that there might be publication bias, i.e. more publication of the positive studies. So this was some really great work a few years ago that looked at all the primary care trials of antidepressants, and they found that in fact there is bias. So what you would normally expect is around the summary effect size, you normally expect to see an even distribution of studies on both sides if there's no publication bias. And you can see here that on the antidepressant ineffective side, there's a big hole. So we know that there is publication bias in particular in the primary care studies as well. The other thing that we have to remember in interpreting these studies for our primary care patients is that The trial patients, even when they're recruited, generally aren't representative of our practice. So this bottom line here is the patients that we see day to day in primary care with depression. But the top line is the ones who are recruited often from hospital settings for trials. So these grey patients here are those patients that are missing in action for those trials, and you see that they're overrepresented in that mild to moderate or lower severity. And what that does to the benefit is that this is the kind of benefit you'll see in the publication of a trial. But if you were to include those patients that we see in primary care, you could see that the benefit is attenuated, and so the point at which the benefit might outweigh the harm is shifted. Bruce Arrell and some colleagues did look at the efficacy in adults in primary care and found that the effect size is around about 15% over and above the placebo effect. But they said that when they looked at that funnel plot, that effect is likely overestimated due to publication bias and also the severity category of the included patients. So this is a best case scenario. So the conclusion really from this NNT is that most people who are taking SSRI, even for the acute episode, are not benefiting from treatment. And we can't tell clinically who is having a placebo effect and who is not. Just matching the treatment thresholds to this evidence, the majority of patients in primary care are mild or mild and moderate. And that does affect the number needed to treat. So again, Bruce Arrell and colleagues, when they looked at this meta-analysis, they looked at the numbers needed to treat for different severities in those primary care patients, and they found that in the milder to moderate range, that number needed to treat really goes up to much higher and really tips that risk-benefit balance. So the NNT, if you're looking at these lower severity categories, is 16. And again, looking at the thresholds for severity, you can see on I'm not a great fan of scores, but you can see on a score that many of you will be familiar with, that it's actually reasonably high threshold when you look at the range of our primary care patients. So in this mild to moderate range, 53% might get better with an active chemical medication, whereas 47% will get better with placebo. So take-home message number 2 really is that antidepressants offer a pretty modest clinical benefit in relieving the symptoms of depression in our primary care patients, and that there are other effective treatments for mild to moderate depression. And we don't have time to address these in the range of this talk today in detail, but I will refer back to these at the end of the talk in our practical piece. So the next reason to rock the boat is the harm. So where is the harm of long-term antidepressant prescription? And increasingly, there's emergent evidence that these are the kinds of risks and harms that patients taking antidepressants long-terms may experience. And I'm just going to dive into 1 or 2 of those. I know that you've covered some of these in previous TI, both publications and in sessions, but I'm just going to touch on a few of those just to look at the extent of that risk. So just looking at the increased bleeding risk, and this is really consistent over a range of studies. There's a very nice reference in the next slide of a meta-analysis that looked at this in detail. And you can see there's an increased risk of GI bleeding, of needing transfusion after hip surgery, and that this risk is further compounded if NSAIDs are co-prescribed. And just to give you a sort of visual image of this is from that meta-analysis, and you can see really that this upper GI bleeding risk is very consistent across studies. And this is important because if you're having surgery, you don't have time to withdraw from your SSRI. So you're kind of stuck with that risk. So thinking about the implications of these risks when you're thinking about whether it's, oh, well, we won't rock the boat, we'll just continue, where's the harm? There are anticipated but also unanticipated potential harms. And just looking again visually, this is the extent of the risk with SSRIs alone and with NSAIDs and then with the combination. And so you can see that the risk of GI bleeding with SSRIs isn't too far from the kind of risks that we're seeing, that we are very aware of with NSAIDs. Another a harm which is often easy to miss is sleep disturbance. So you can see here that there are a range of sleep effects of SSRIs that can affect sleep quality and the ability to sleep. So insomnia, and we know that insomnia is something that really is very important to patients and really troublesome in terms of their quality of life. And so you can see there's a very consistent effect on sleep. And so this is another example too of a prescribing cascade, or certainly a symptom cascade, that if you have a patient who's on an SSRI who's having trouble sleeping, think, could this be the drug? And so I've just given you a couple of examples, but the intersection of all these potential harms is here in our most common patient, which is the patient with multimorbidity. We all know it's very rare for depression to exist in isolation. And here's Anne, who's 85, and she's had a fall at home, and you can see her medications on the right. And so it's in this patient that SSRIs just form part of a cumulative burden of these risks. The rate of chronic antidepressant use in long-term care in Canada is much higher. One Canadian study suggests that it's as high as 60%. And you can see here that serotonin toxicity, it's easy, it's bound or obvious when someone's got full-blown serotonin syndrome. It's much easier to miss when somebody's got subthreshold serotonin syndrome. And you can see here some of the symptoms of serotonin toxicity. And you can see here that, oh, I don't know what's happened, I'm going to go back. You can see here that these are the kinds of things that might be subtle and nuanced and very easy to miss in older adults as a drug side effect. In our recently prescribing study, and amongst the first 10 patients we had in the study, we had a case of subthreshold serotonin syndrome, which had been undetected in a patient who just started to get a little more confused, had a couple of falls, and a bit agitated, and had been brought in by her daughter. And it wasn't until we realized that a slightly serotonergic drug had been added to her SSRI that was what was going on. Bleeding is another cumulative side effect, and we've really talked about that. But you can see that these are kind of common agents that our primary care patients are on. So you can see it's really easy for that cumulative risk to mount. Atorvastatin is associated with increased risk of intracranial hemorrhage in patients who've previously had a hemorrhagic stroke or TIA. So these are easy cumulative burdens that are easy to miss. And the same QT prolongation. It's unpredictable, and its effects are probably invisible, because in our older adults, the manifest is a sudden cardiac arrest and death. And unless somebody was doing an ECG at the time, then that's largely invisible. The other reason to just speak of the subgroup of older adults, because this is the cohort in which, if we don't stop these medications, who will end up taking them into older age, is there's much less evidence for benefit in older age. The remission rate differences are less, as is the response rate, where the absolute difference is around 6% for remission. There's no primary care trial evidence in this population, and there's really an absence of evidence in those with multimorbidity that's significant or significant frailty. And it's important because there's a risk of falls in seniors, and traditionally we think about tricyclics and falls, but in fact the comparative risk is consistently higher for falls with SSRIs than it is with TCAs, and there's a very consistent dose response with that and with fractures. And really the last point to think about in thinking about your older adults and whether to stop SSRIs is that in patients with dementia, there is evidence that they are not clinically effective compared to placebo for depression in patients with dementia. So there isn't an absence of evidence, there is evidence of no effect. And that's really important, because sometimes when the diagnosis isn't clear at the beginning, is this a mood disorder or is this a dementia, then an antidepressant can get started, and then a diagnosis of dementia is subsequently made, but the antidepressant stays. So that's a really important point to think about. So take home message 3, there are great reasons to limit the duration of prescription to only that's necessary. So the next question is when to stop. Most of the trials for the evidence of effectiveness in the acute episode of depression only extend to around 8 weeks. the evidence, the lesser evidence that goes beyond that suggests that continuation to 6 months is likely to be of benefit. And thinking of that model of what are we doing it for? It's to relieve symptoms, and that's the usual kind of duration of an acute episode. There's really more limited evidence for effect out to 12 months. And so the general recommendations that you'll see are for around 6 to 9 months after remission. So the take-home message for this is that really I talked about legacy prescribing, and legacy prescribing is likely to be a system issue, because we're really in the prescribing world for intermediate course drugs. It's a bit like driving on roads with no stop signs. We have great systems for starting medications, but our prescribing systems aren't really set up for stopping. And so a really useful practical tip is that whenever you're starting a medication, an antidepressant medication, set up their patient expectations for the duration of the treatment course at the outset, so that the typical course for antidepressants is 6 to 9 months, and we'll review that at that time, put a note, a reminder in the chart, and locate that for the patient. So you can say, next spring is around about the time at which we'll think about slowly tapering you off. So setting those expectations from the beginning. So now moving to looking at the evidence base for stopping. Previously, our recommendations were based on a single meta-analysis, and that was referenced to most of the guidelines. And this was a meta-analysis that appeared to show a substantial effect of continuing treatment versus coming off. And the absolute difference in the meta-analysis was 23%, and the number needed to treat was 4 to 5. But there are a lot of, when you drill down into the trials that underpin that meta-analysis, there are tons of flaws there that would give you a bit of pause in interpreting that in our primary care population. Almost all of the trials were done before the need for tapering was known. Many were short duration, and in fact, what they called maintenance was still during the acute treatment stage, so they were tapering people within the first 6 months. The outcome measures were pretty poor. It was things like return of symptoms, which, if you know what we know now about withdrawal symptoms, there's a huge overlap with an episode of depression. And there were no trials in the primary care population where we know 90% of the management and the prescription occurs. Interestingly, looking at these trials, when you looked at the recurrences, most happened in the first 12 weeks, which is kind of incongruent with what we know about the natural history of the illness. And people who have recurrent episodes of depression, the episode isn't sitting there waiting to reappear as soon as you taper off see an immediate rise in blood sugar. So that bulge in recurrence did fit with something else going on. And with withdrawal syndrome, there's huge potential for confusion with relapse, which we'll talk about a bit more. We know that 2/3 of those on shorter half-life SSRIs will have withdrawal symptoms. In the early lithium studies, a similar effect was seen when lithium was just stopped without taper, was that withdrawal symptoms were confused with the recurrence of the illness. And so this idea of return of symptoms of depression was likely to result in the miscoding of withdrawal as a relapse or recurrence. We have 2 recent primary care trials that give us some idea around maintenance. Both were comparing ongoing maintenance in people who've been taking antidepressants for well beyond the acute episode, and comparing ongoing versus stopping in currently well patients. I should note my conflict of interest here. So I was the co-investigator on the first trial I'm going to talk about, and I'm the lead investigator on the second one. So you need to interpret what I say with that in mind. But I can tell you in detail about the trial. So primary care trial number 1 was a multi-center double-blind RCT with 12 months of follow-up. So it looked at stopping versus continuing and what happened over the following 12 months. And it looked at stopping a variety of SSRI antidepressants. The blinding was done with over-encapsulation of the tablets or over-encapsulation of a lactose tablet. And it's a slight problem, because we know from all the trials that I've ever been involved with that patients will undo that over-encapsulation and have a look and figure out what they're taking. And it used a linear 2-step dose increase. So they went from to 50% to 25% to stopping. And the primary outcome was recurrence of depression of any severity using the ICD-10 depression diagnosis with those two key symptoms, using a CSI as just a clinical interview based scale, which makes sure that those two key symptoms, which we know are a requirement for depression diagnosis, were there. And what that trial found was that the absolute risk difference for relapse in the 12 months after was 17%. And you can see the differences in the two arms there. And number needed to treat of 6 in 1 year. But when you looked at the relapse symptom score, the difference between the arms was relatively mild when you look at the PHQ, and there was a pretty high study medication discontinuation rate in both arms, and it's not clear what the reasons for that. That you can imagine they could be heterogeneous, could be patient preference, withdrawal symptoms, that kind of thing. And we know that discontinuation rates are always really high in studies of depression and antidepressants. Primary care trial number 2, which is not published yet, but hopefully will be shortly, was a multi-center double-blinded placebo-controlled RCT again. It used fluoxetine only because it was less likely to result in misclassification of withdrawal and recurrence. There's no such thing as withdrawal symptoms with fluoxetine, but certainly it's reported as one of the antidepressants with less. It used a non-linear taper, so with increasingly small steps and 4 steps. And the blinding was identical pink powder filled capsules. There was an operationalized definition of withdrawal symptom, which involved when somebody had mood symptoms, if they had withdrawal symptoms as well, there were a blinded adjudication of, does this look like mood symptoms related to withdrawal? Are there enough withdrawal symptoms to suggest it might be? And then does it go away with an unblinded restarting of the medication within a short time? And this was a slightly longer follow-up at 18 months, and looked at not occurrence of all depression, but occurrence of moderately severe depression or higher, so that which you would normally treat with a medication, and again, standard kind of DSM-based diagnosis. So in that trial, what we found was that the absolute difference in recurrence for moderate to severe depression was about 12% between the arms. That of the people who restarted medication, that 6% of the difference in that was clear withdrawal symptoms. So between arms, 12% had what appeared to be a recurrence, which didn't fit criteria for withdrawal symptoms, but 6% had clear withdrawal symptoms that made the discontinuation intolerable. There was a 10% dropout rate, and this was due to a variety of reasons that informed patient preference, just wishing to restart active medication, but no sign on the ways that we chose to assess it of subthreshold depression or psychological distress. But this was a lower rate than other existing trials. And you'd see I've got a no tweet sign on that, so we haven't published it yet, so I'm sharing it with you because I hope it's useful, but please don't disseminate this until we can get it published. So the other thing that we assessed in that trial was is there any harm in trialing stopping? And so we looked at the 18-month point at a range of measures of kind of well-being as well. So our conclusion from the primary results were that in primary care, that maintenance antidepressants prevent an episode of depression of a severity that might require medication in the subsequent 18 months in around about 12.8% of patients. So the number needed to treat for 18 months was around 8. And you'll notice that 12% rate is quite similar to the population estimates of the proportion of people who experience an episode of depression in any 1 year. So that does prompt us to sort of think about, okay, is it better, a little bit like urinary tract infections, is it better to continue the medication because it will treat the symptoms when it comes, or is it better to be very alert to those symptoms and start the medication in a timely way when you get an episode? So that's a useful conversation to have with patients. And I think the other key thing was that for every 16 taking fluoxetine, 1 was unable to discontinue, even with a taper, because of intolerable withdrawal symptoms. So that's a number needed to harm of 16. On those measures of were patients worth off for trying to stop, we found no suggestion of poorer outcomes across a range of quality of life measures at 18 months in those who trialled stopping versus those who didn't. And that we found also that nearly half could successfully discontinue of these patients who've been on antidepressants for in many cases, over a decade. So the conclusion was it seems reasonable to offer a trial of withdrawal. The number needed to trial withdrawal for one to successfully come off over an 18-month period without either intolerable withdrawal or depression recurrence was 2. So thinking about the domains of withdrawal symptoms, I really put this slide up to just acknowledge it, because I know that you will all be very familiar in your clinical practice of the domains of withdrawal symptoms. But the key point I wanted to make is that these do, if you were to apply some of these research tool type rating scales, they do result in a change of depression scores, i.e. they can look like the original indication of depression. And so thinking about in your clinical practice how to distinguish that, using some of the things that I mentioned before, is are some of these pathognomonic, is the patient experiencing, as well as a mood change, some of these pathognomonic physical symptoms of withdrawal? Do they talk about the mood symptoms as being qualitatively different to the kind of mood symptoms that they experienced when they were having an acute episode of depression? And if we start the medication for a few days or increase the dose back up, do those symptoms quickly disappear? Because we know that the symptoms of depression won't rapidly ameliorate. So the take-home messages from these trials, I think, are that most people are not benefiting from maintenance treatment. That it's reasonable to offer stopping, a trial of stopping to all patients with a discussion of the pros and cons, that most, if they trial, will be able to discontinue, but some people may not be able to stop, and really shared decision making, as with all things we do in primary care, is the best approach. So now, leaping into the void, I'm now going to move into a more evidence-free zone of some practical suggestions for how to go about stopping antidepressants. And the first thing is, I think, how to address the fear that we have and that the patient has of stopping. We know that patients think the idea of a drug holiday is a good idea, that they should pause their medications every so often. And so I think the framing of stopping is really important, that as with all deprescribing, to frame it as pause and monitor. We're going to drop the dose a bit, or we're going to pause, but then this is an ongoing conversation. We're going to monitor and see how you're doing and how you're feeling. That this is a very gentle art. If someone's been on a medication for 10 years, there's no rush to stop it. And we'll talk a little bit more about that time period in a bit, but every drug deserves a holiday. I don't like the term deprescribing, because sometimes in patient conversations, they can interpret that as we're going to stop this and then there's no possibility for restarting, and that just ramps up the fear. So this drug holiday or pause and monitor is a more appealing way, I think, of framing what you're actually going to be doing, with a clear plan for follow-up in that ongoing conversation. And again, I've talked about trials and wisdom and critical clinical judgment and the clinical interpretation of what little science offers us here. And when we translate these partial statistical lives of trial participants into the real lives of the patients sitting in front of us, that observation of the individual response to the effects and side effects of treatment is key. And so really every taper and withdrawal that we do is an N=1 trial. And listening to what the patient says they're experiencing, believing that is key. One of the really important aspects of the process is shared decision making and understanding what matters to them. And so these wonderful young people did some work a few years ago looking to see if there's any tools that we might use as conversation triggers to figure that out. And what they found was that there were no tools, and also we found, which was very disappointing, was that their patient experience of these conversations was very negative, that they found that the initiation of the discussion of what mattered to them was rare, that they felt often a negative response if they raised the idea of discontinuation, and they felt a bit powerless in these conversations. And so as part of this study, we did an approach of appreciative inquiry. So we asked what were the key factors when these conversations went well and when they didn't go well. And you'll not be surprised to hear that when things went well, The key aspects were recognising the patient and family's expertise in the conversation and their lived experience of both illness and the effects of medication, both taking it and stopping it. That when that was recognised, things went well, and when the practitioner was perceived as being patient-centred in the approach. So it's great because it reinforces very much a primary care generalist approach. So these are the kinds of domains of questions that came out from that work. And this is what patients want us to ask them. What are the things you'd like to be able to do that your health or your depression symptoms stop you? What symptoms do you most want medicines to help with? What don't you want treatment for? What don't you need the medicines to help with? And how important to you are treatments to prevent future illness versus ones that treat your current symptoms? In the process of stopping, I use an acronym PET, and that's prepare, engage, and taper. So just going through these sort of practical approach to stopping medications. And the first thing really is dealing with the myths, and in particular the serotonin deficiency myth, and this idea that if they stop the medication, that the depression is lurking there, ready to immediately re-emerge. So understanding that the drugs are for symptom control, and the episodic nature of depression is really important. And also explaining to patients that stopping may be easy or it may be more difficult. So to manage those expectations so it's not a surprise. And that patients who've been on antidepressants for a long time, you may need a long taper, that there's no rush. Preparing them for the discontinuation effects and reassuring them that even though they can be awful and very noxious, they're not life-threatening. And warning about the rare but important withdrawal symptoms, just as with starting medications, with stopping SSRIs, you can get emergent suicidal ideation, and also in a small group of patients, akathisia, which is very, very distressing and alarming. And so to warn them specifically, but also tell them what to do if they start to think they're experiencing those symptoms. So you'll see in these next few slides, I've put some script in pink. So this is kind of sort of scripts that might help you with those kinds of conversations. The next step is engagement. So letting patients know that aside from that rider about that smaller subset who do experience very noxious withdrawal syndrome, that they generally will be no worse off for trying to discontinue, suggesting that they engage family and friends as supports, and optimizing the non-pharmacological management options. There was a study in 2019 that showed that if you put in place psychological supports at the time you're trying to discontinue, your success rate is much higher. And I mentioned at the beginning that there are a number of other ways of managing mood symptoms that are shown to be effective, that it makes total sense to engage with these before you start the taper period. Exercise, we have tons of evidence for, but again, this is a journey we walk with the patient, so it's important not to just say go and exercise. It's really important to prescribe that exercise and to manage and monitor that just in the way that, and check in just in the way that we would any other kind of prescription. And also addressing other psychosocial issues. If there are relationship issues that are causing mood effects, obviously those need addressing before you attempt that tapering journey. Documenting, it's really important to identify and document the reasons for the discontinuation and ensure good planning and communication with the patient and any other clinicians that are involved in the frame, and framing that as a pause and monitor a drug holiday. The next thing, practical thing to think about is how do I go about stopping? And we have little evidence to guide the best way to stop SSRIs. There is evidence that some have more significant discontinuation effects than others, paroxetine and venlafaxine in particular. And this is a really important consideration when you're choosing a treatment to start on. And various approaches there have been advocated, switching to a longer half-life. There's no often it's recommended to switch to fluoxetine because it's the longest half-life, but there's no evidence this is beneficial. But different preparations may make the tapering regime easier. So that's an important practical consideration. Tapering off seems rational, but there's poor evidence for the rate of taper. a review in 2021 examined different tapering regimes that had been tried in different trials, but most of them were very abrupt and short term. And for the less than 4-week taper was really not that much different from stopping it abruptly. But it didn't really compare various other longer term strategies. And so there are a variety of perspectives and opinions on this. People and clinicians who see a lot of patients who have protracted dreadful withdrawal symptoms would probably advocate for a different approach to those who've seen patients, and we've all seen patients who've actually stopped themselves abruptly with no issue. The only other thing to flag is that sometimes alternating days are recommended, but this can actually be really unhelpful, especially with the shorter half-life drugs, because like paroxetine, because what you're doing is giving them a mini withdrawal every second day, sort of on and off, and that's usually relatively unhelpful. Also, half-life is a very simplistic way to think about tapering, because not only do drugs have different half-lives, but they also have, in terms of their serotonergic activity, different potencies. And we also know that these drugs aren't magic bullets. They don't act just on the serotonin system. They act on a variety of systems, calcium channels and other things that may or may not be involved in those discontinuation symptoms. So, in summary, tapering should be a gentle process. That at the outset, the criteria should be agreed on when you might restart, and this should not be seen as good as failure, but just good monitoring. And that tapering, as a rule, seems sensible in most deprescribing. Thinking about how to taper. It's important to remember that there are no rules that state that tapering steps and intervals should be regular. And we know that many people report the most trouble towards the end of the taper of SSRIs and need much, much smaller steps at that end. And this is because of the serotonin system, but also the other systems that might be involved. And there was a study done that some of you will be familiar with from a couple of years ago that showed that there may be one of the reasons why people have trouble at the end of the taper, and we shouldn't use linear tapers as automatically as has been recommended. And you can see here that this graph represents not half-life, but it represents the serotonin receptor occupancy at different doses, and this is citalopram. So you can see here, as you look either visually at the graph on the left or the table on the right, depending on your preference, that you can see that for the same step down in serotonin receptor occupancy, the increasingly small incremental dose reductions are needed. So that's really important to bear in mind. And the other thing to note about tapering is all SSRIs need tapering, even fluoxetine. In our trial, even using fluoxetine and with a taper that used incrementally smaller steps, we still saw withdrawal symptoms, and that those were delayed because of the long half-life. So we tended to start to see them often about 8 weeks after the tapering period was finished. So it's easy to miss them. And easier to put them down to irritability or kind of mood issues. So everything needs tapering, and the recommendations previously had been if you're taking fluoxetine, you don't need to taper. You do. And the rate of taper is very individual, and a test drop in dose can sometimes signal that what your initial rate might be. And communicating that rationale to the patient is really important. Is critical because they're the ones that will experience the discontinuation symptoms. So you could suggest that if 10% seems to have no effects, then you could shift that first step to say 25%, but if not, stay at 10% or less. And I've mentioned that tail of the taper issue. So in monitoring, it's really important to have a clear plan about what you're going to monitor, what's important to you and what's important to the patient to keep an eye on and track, who's going to monitor them, and how often you're going to reconnect about that, and what your agreed criteria for restarting are, to be really clear. And patients will feel more reassured, and I do too, actually, about trialing a taper if it's framed as this pause and monitor process. Because the idea of not being able to restart is one of patients' expressed fears about the deprescribing of any medication. Some other practical tips for those needing smaller incremental drops. We know that the formulations available are a real pain in the neck for doing this really boutique taper. But for those needing smaller incremental drops, you can tablet split or get a liquid preparation, and most most places have a local compounding pharmacy, but the problem is that that costs the patient. And if the patient can't afford compounding, there are other options. You can switch to a medication that has better forms, but also most tablet forms that aren't extended release are soluble, they're water soluble, and what you can do is dissolve those and then using a syringe, take a proportion of the resultant well-shaken liquid to calculate a taper. But it's really important to consult with a pharmacist and work together as a team to confirm that solubility and to support the patient to make sure that they're really careful and able to do that. And the other point, I think, is that some people, as we saw, may not be able to discontinue completely, but the lowest dose required to control the discontinuation symptoms will minimize the harms of the medication. So to quote a friend of the TI, James McCormick, dose size does matter. And one of the last points about how to stop antidepressants is this is really front and center within the superpowers of primary care. So relationship-based care and walking with the patient through this journey is really important, particularly for those patients who experience extended withdrawal or discontinuation syndrome. It's really important to check in regularly, to acknowledge their experience, and to make sure that, as with any journey with chronic illness or symptoms, that that you make sure that they know that you are there with them for each step of the journey. So just to tidy up for our question time, one of the things I love about Canada is skiing in the trees, because we don't have trees on the ski field in New Zealand. So when I first tried here, though, I just seemed to keep skiing into the trees. And I knew I could do short enough turns to get around them, so I couldn't figure it out. And I talked to one of the Canadian mountain hosts, actually out in BC, about this, and he said to me, well, that's because you're looking at the trees. And if you look at the light between the trees, it will be completely different. And he was quite right. It was an instant and magical fix. So there's a new paradigm that's emerging from primary care called Quaternary prevention, or P4, and that's actions to reduce the burden and harms of excess care. And thinking about how we value and make this kind of care more visible in our systems of care. So I think this is a really great example of the light between the trees, and a massive opportunity we have to improve care and reduce unnecessary medication for patients. So all good reasons to think about when you are in a calm patch of water, there are good reasons to just gently and safely rock that boat. So I'm going to finish there, and I know, Aaron, you've been looking to see if there are some questions, and Aaron's going to take the tricky ones, and I'll answer the easy ones.
Of course. Thanks, Dee. That was wonderful. You're so calm and such a great presenter. I learned a great deal, and it's a pleasure to listen to you. Maybe to give you a break to have a sip of water or a sip of tea, just remind participants that you'll be receiving the evaluation form in the email, and whether or not you wish to receive education credits, we still value your comments on the evaluation form, so please send those in. And if you do wish the credits, we'll send them to you. There are a number of comments and questions in the chat, so I best get started, Dee. We have about 5 minutes. So I apologize for those of you that I don't get to your questions because of the time, but we'll do our best. So one of the questions was one of the comments was that practitioners find a challenge that other effective treatments for depression are hard to access for patients, especially patients with little resources. So wondering if you had any comment.
Yep, I agree entirely, and it's a huge deficiency in the system. So it's figuring out what resources are available to you locally and looking for online resources. And in fact, if you have a look on, we have a web in my sort of other recent life, I've been involved in a clinical care pathway for COVID, and it's on a website called hfam.ca. But there we've also curated a range of resources for managing anxiety and depression virtually. And so maybe afterwards we can post the link to those. So those are things that do make those kind of resources a bit more accessible, but that is a huge barrier. But the exercise piece is accessible, and for patients experiencing withdrawal symptoms, sometimes they're so severe that they just can't managed to get out for the sort of typical forms of exercise. And one of the things that exercise seems to do is it seems to engage the motor part of the brain. And so one of my patients, for example, who was taken 5 years to get her off her paroxetine, but she now is off and feels like, she says, I feel like I have my life back again. And when she was so ill from the discontinuation symptoms, she was a knitter. And so I said, try this, just, you don't have to knit a thing, just knit, knit a piece and do a little bit each day. And it engaged the motor part of her brain without her having to make the effort of going outside for a walk. It was mindful. That was all she could concentrate on that moment. And it gave a sense of productivity. So she would bring in her knitting to each appointment and show what she'd done. So there are other ways to kind of think about how to do those things. I can see a couple of things at the bottom of the messages. One was about dose, a way to minimize the difficulty of stopping is dose, and I think that's true. A lot of the doses that are recommended for treatment are averages, and many patients need less, in fact, to get an effect. There's a strong flattening of the dose response curve, as you can see with that graph I showed of serotonin receptor occupancy. Often you need much lower doses than are the standard recommendation to achieve the effect. So I think that's a great point. A couple of things about post-SSRI sexual dysfunction. Yes, it is a thing, and you'll see. I know you've had a previous talk at the TI that talks about that in more detail, but the sexual dysfunction with antidepressants can occur even with just short-term use, and it can persist after stopping. So again, another, it was in the list of potential harms, another good reason to think carefully about before starting.
Great, thanks, Dee. And that link for resources, if you send it to us, we'll post it on the website with the recording of this talk. And just be mindful of Dee's request to not share the results of the trials prior to publication. So another question here. I would love to hear the details of how you tapered fluoxetine in your study.
Yep. So we used an incrementally smaller and smaller dose. So we didn't use a linear step down. We decreased the, and it depended on the starting dose as to what the schedule was. So we had a different schedule that the pharmacy who put the powder in the capsules used, and they just very slowly reduced the proportion of the active drug in the capsules compared to the placebo. But as I said, the step down in the second study was a gradually reducing incremental step compared to the first study. I know in the UK they were more limited by the preparations that they had available to them and the fact that they had to over encapsulate. So it was quite the challenge to do the powder-filled placebo pink capsule for both arms. We had to get a license to manufacture placebos, and it was a complete nightmare. But yeah, so the taper that we used, which I think resulted in a greater effectiveness and be able to discontinue, was that one that I recommended, which is a incrementally smaller steps. And I think outside a trial, and within a trial, the way that funding and trial duration and things work, it's not possible to do what we would do in real life practice if you're going to blind with placebos. But in real life practice, then I think that often it'll take years to come off. And I think the slower you can go, the more likely you are to be successful, and really sticking to that of paying attention to what's going on with the patient. And if they're starting to get a few more withdrawal symptoms, then you could increase the duration between steps and decrease the size. So very much leaving the patient in control of that, and particularly paying attention towards the end, I think is really important.
Okay, thank you, Dee. And it's 1 o'clock, but if I can give you a rapid fire question, any specific pearls for tapering older adults versus younger ones, especially if dementia may not allow for a full symptom check?
I think you just have to use your powers of observation and the caregivers who are close to that older adult to, to observe, notice difference in behaviour, differences, and older adults with cognitive impairment will tell you about physical symptoms that they're experiencing. They may not have memory, but they will be able to tell you in the moment, or express the fact they're having symptoms. So I think, again, if they've been on them for 10 years, you can go slowly. And we do have a paper, and I can put the link into it, or if anyone wants to email me, I can share it. Unfortunately, it's behind a paywall, so I'm not allowed to just post it. But we did write a paper called Breaking Up is Hard to Do, that specifically was focused on approaches to discontinuing medicines in long-term care patients. So please do drop me an email and I can send you the PDF.
Okay, Thank you, Dee. Once again, thanks to everyone for taking some time out of their day to spend with us. I hope you found it useful. I certainly did. And Dee, it was a pleasure to have you speak, and always educational and lovely to see you again. With that, I'll close it for the day and hope to be in touch with any and all of you at any time you wish. So thanks very much.
Thanks for having me.